All right, everybody, let's finish up this last week of our drugs and behavior class by talking about different types of anxiety disorders and the treatments that we have for them. So I'm going to give you an overview. Now, whereas when we talked about mood disorders, we only really talked about depression and to a lesser extent bipolar disorder, there are several different types of anxiety disorders. And we're also going to talk a little bit about obsessive compulsive disorder as well as PTSD, although neither of these are technically considered anxiety disorders as of 2013. With the publication of the DSM-5 in 2013, OCD and PTSD, which were previously considered anxiety disorders, are no longer done so, though they do share a few common features with other types of anxiety disorders. We'll talk about what anxiety disorders do to the brain, and then we'll finish up by talking about different drugs that we use for treating anxiety, OCD, and PTSD. Now, some of those drugs we have already talked about. Antidepressants, especially SSRIs, are very common treatments for anxiety disorders. But in this section, we're also going to talk about benzodiazepines, and we're going to talk about barbiturates. So let's start by talking about some of the major characteristics of anxiety disorders. So I kind of mentioned this already, but the DSM-5, with its publication in 2013, reclassified anxiety disorders into three major categories. So we still have our anxiety disorders, which will include things like generalized anxiety disorder, panic disorder, different types of phobias, as well as social anxiety disorder. Obsessive compulsive disorder has been grouped with other related disorders regarding impulse control. And then finally, we have the trauma-related disorders, which do include things like PTSD. Now, anxiety itself can manifest in a variety of different ways. Now, acute anxiety, so anxiety that we kind of get in the moment. It's typically not very long lasting, like the fear that you might feel right before you have to give a really big speech. If it doesn't happen all that often, and this speech of yours is a really big deal, it's not long lasting and it may not be considered a clinical disorder. Remember, this needs to be disruptive to your life in some sort of way, and it needs to hurt your ability to function. Now, for some people, anxiety symptoms may not have like a particular focus. So maybe for some people with acute anxiety, they sometimes get scared at big stakes speeches, but they're fine the rest of the time. Somebody else who might have an anxiety disorder worries about a variety of different things. And additionally, these symptoms can be present for a good chunk of the day, and they can actually persist for years. So we'll see different things like maybe episodes of panic, avoidance of anxiety eliciting stimuli or anxiety inducing situations, which is known as situational anxiety, intrusive thoughts, compulsive behaviors, and really damaging negative thinking patterns. And as we talked about last week when we talked about mood disorders, anxiety is often going to be comorbid with other types of psychopathology, such as clinical depression. Now, what are some of the major hallmarks of all of these disorders? You're going to experience things like feeling of concern or worry above and beyond what would be considered normal. You're not really going to be able to relax. You're going to have a lot of increased muscle tension. You can't let your body relax. And likewise, it's hard for you to let your mind relax. There's restlessness, impaired ability to concentrate, sleep disturbances, and irritability. Now, on the physiological side, anxiety disorders are very highly correlated with activation of the sympathetic branch of the autonomic nervous system. And this is going to produce a variety of different symptoms, including things like an increased heart rate, lots of sweating, and other signs of a fight or flight response. Now, as I kind of mentioned, some anxiety or fear-based responses are helpful for us. Remember that anxiety can be critical for our survival. And this is important. This warns us about things that could be dangerous or could potentially kill us. And it's also going to help activate that fight or flight response. Now, in modern life, we're going to see that this fight or flight response may not actually be beneficial to us, particularly if we need to make a speech or if we're having to take some sort of exam, where it's much better for us to stay calm and stay focused on the exam in front of us. So here you can kind of see some of the different effects that you might experience if you are dealing with stress. And remember that stress in particular is a function not just of the environment around you, but it's also going to be related to how you view the stress. So here you can kind of see a 3-component model of anxiety that has been proposed. This was proposed by Rosenthal and Rosenthal back in 1991 or 1980. I don't know why I said 1991. But here what you can kind of see, stress basically induces, so here's what's really critical. It has to be perceived as threatening. If you don't perceive it as threatening, none of these other events are going to happen. But you've got these stressors, and that can include things like failures, personal losses, things that are scary, time pressures, being insulted by somebody. And you're gonna, if you perceive that and appraise that as a threat, you're going to encounter these 3 different things. There's an interaction between the bodily effects, the upsetting thoughts, and some behaviors that you may potentially use to cope, but ultimately can be ineffective in helping you manage that stress. So from the bodily perspective, a stressor is going to induce an autonomic emergency response. You're going to start hyperventilating, engaging in shallow breaths. And of course, we know that it's been pretty well documented that shallow breaths lead to hyperventilation, which can potentially lead to panic attacks, even if you're not aware of it at the time. You're going to experience things like a pounding heart, tense muscles, digestive issues, sleep disturbances, fatigue, and maybe psychosomatic illnesses. So while these bodily effects are going on, that is potentially creating upsetting thoughts, things like anger and fear and preoccupation, self-doubt, negative self-talk, repeated thoughts of being in danger, or worry about body reactions, which, if you don't know, typically makes those bodily effects even worse. And at the same time, you're engaging in these ineffective behaviors, all of which influence each other. You're engaging in things like escape behavior, avoidance, indecision, aggression, inflexible responses, bad judgment, inefficiency, and potentially things like drug use to cope. Now, for other people, this is not going to be an issue because the stressor might be perceived as something that is challenging that results in more constructive, effective behaviors. And there are some individual differences here, kind of based on genetic traits, early exposures to stress or trauma that are going to make some people more or less vulnerable to these different stressors. Now, I'm sure many of you know that at the time that I'm recording this, Inside Out 2 is currently in theaters, and it introduced the character of anxiety. And I haven't watched the movie yet, but I have seen a couple of trailer clips. And one of the things that I think they absolutely nailed was the relationship between anxiety and fear. And anxiety explains that fear is for the things that Riley can see. the things that Riley is dealing with in the present. Anxiety is there to help Riley manage all the things she can't see. And I think that that's a really good way to think about anxiety and fear. Fear is ultimately an emotional response to clear and present danger. It's currently what is going on in your world and in your environment. Anxiety is different. Anxiety is not present focused. It is future focused. It involves apprehension about future events and future misfortunes. And one of the things that we do find is that they differ in terms of their psychological and neurobiological consequences. So let's start by talking about each of these disorders in a little bit more detail. So we have generalized anxiety disorder, or GAD, and this is marked by constant worry and continuously trying to predict, anticipate, or imagine dreadful, unpleasant, or aversive events. And for these people, life is full of stressors. Everything that maybe somebody who's not struggling with this disorder would shrug off. Life is going to be really stressful, and even those minor events are going to provoke a lot of worry. Now, because the mind is so occupied by these different worries and these different things, we also know that chronic anxiety can actually reduce an individual's performance on a variety of different tasks because they can't really focus. And it often decreases their sense of pleasure and joy in things. And one of the other things that we know is that generalized anxiety disorder does affect the amygdala. Researchers have found that there's increased volume, but to a greater extent, what we are going to see is greater activity in the amygdala. So we do see increased volume in the amygdala, very similar to what we would see in lab animals that are exposed to chronic stress. And metabolic PET scans have shown greater metabolic activity in the amygdala when you are looking at different negative stimuli, if you have GAD compared to healthy individuals. So there's a greater, more intense, more active amygdala response when being presented with negative stimuli compared to healthy individuals. Now let's talk about panic attacks and panic disorder. You can have panic attacks without having panic disorder. So a panic attack is basically the effect of a fear reaction, typically in the absence of a threatening stimulus with a very strong arousal of the sympathetic branch of the autonomic nervous system. So again, we're going to get those very strong autonomic nervous system responses. And what's really critical, again, for this to be considered a panic attack, there doesn't actually need to be anything that you are responding to. For a lot of people with panic attacks, these will often occur out of the blue. Now with panic disorder, this is going to be different. They have to experience both panic, those individual attacks, and they have to be worried about the possibility of having an attack in public. If you do not have that anticipatory anxiety along with the panic attack, you do not have panic disorder. Now, one of the things that we do find is there is a significant fear around having a panic attack in public, and you can kind of see why. They can be really debilitating, and they may invite a lot of public attention, which somebody may not want in the middle of that kind of a situation. As a result, panic attacks will often lead to what is called agoraphobia. This is a fear of public places, and as a result, you're going to see a lot of people with agoraphobia avoiding a lot of public situations where they won't be, a lot of public situations where they could be perceived or could be seen. And oftentimes people with agoraphobia are going to lead very limited lives because they never really leave their own house. Now, here are some typical situations that a person with agoraphobia might avoid. This includes things like shopping malls, being far from home, being at home alone, being in a car, being on a bus, a train, a subway, wide streets, tunnels, restaurants, theaters, escalators, elevators, planes, crowds, stores, supermarkets, and waiting in line. Now, a phobia. Now, I don't know about you, but this little corgi is quite cute, and I would probably not have the same response as this man is. This man is experiencing a phobia of dogs. So the phobias are going to involve fears that the individual recognizes as being irrational. And here's what's really critical. We are going above and beyond what one would consider a simple fear. I'm afraid of snakes. Having said that, I'm not afraid of going outside in my yard, even though I've occasionally seen a couple of snakes there. Most of the time, a snake's probably not going to hurt me. But somebody who will avoid their yard, going out in their yard for months because there was a snake in it at a previous time, that might be considered a phobia. It's the extent to which you are willing to go to avoid it and the intensity of that fear. And phobias can affect your daily existence and reduce the quality of life. So here are some pretty common forms. Common ones are with an asterisk. And some less common ones. So acrophobia, commonly a fear of heights. Claustrophobia, fear of closed-in spaces. This is something that the football sportscaster John Madden actually had. John Madden was so afraid of closed-in spaces that he was not able to fly. And so when he would travel, he would often travel on the road by a bus. We have hematophobia, which is blood. Monophobia, which is being alone, thanatophobia, which is a fear of death, xenophobia, which is a fear of strangers, and then we have a few less common ones. This includes ichnophobia, sharp-pointed objects like knives, ailurophobia, cats, algophobia, pain, I forgot astrophobia, storms like thunder and lightning, nyctophobia, darkness, ochlophobia, crowds, pyrophobia, fire. So there are a variety of different phobias that people might have. Now, let's talk a little bit about social anxiety disorder, which can be abbreviated SAD, not to be confused with seasonal affective disorder. Now, here's what's really critical. This is marked by a fear of being evaluated or judged by others. So we're not talking about somebody who is afraid of crowds just because there are crowds there. These people are afraid of others because they might be rejected. And oftentimes what we are going to see is that people who struggle with this disorder may avoid most interpersonal situations, or if they're unavoidable, they might suffer extreme anxiety, and that might lead to a panic attack. Now, here are some of the different emotional and behavioral symptoms of social anxiety disorder. Fear of situations where you might be judged, worrying about embarrassing yourself, concern that you'll offend somebody, fear of talking with strangers, worry that others will notice that you look anxious, fear that sweating, trembling, or having a shaky voice may cause you embarrassment, fearing events where you might be the center of attention, being anxious, anticipating a feared activity, spending time after a social situation finding flaws in your performance. Now, for all of these anxiety disorders, onset does typically occur pretty early on in life. Half of affected individuals are going to start developing anxiety symptoms, usually by about the age of 11. So that's one thing that we know pretty well. Now, one thing that we do find, while medication may be beneficial for some people with anxiety disorders, particularly those that are struggling with panic attacks, one of the things that we do know is that cognitive therapy can be really helpful. Additionally, dialectical behavioral therapy can be helpful. Cognitive therapy, especially those that modify negative thoughts or negative thinking, such as the likelihood of looking foolish plus social skills training, this is really going to be beneficial, especially for people with social anxiety disorder. Now let's talk about post-traumatic stress disorder. This is a case where individuals don't only feel fear, but they feel a sense of helplessness and horror. Now, this has changed. So when I was coming up and I was learning about PTSD, I was always told it had to be firsthand experience. It no longer has to be firsthand experience of a traumatic event. You can have this happen second or third hand, and that would count as PTSD. So people may experience nightmares and flashbacks about the event. This could be things like war, crimes, assaults, car accidents, natural disasters, things like that. So nightmares and flashbacks, numbing of emotional responses, avoidance of social situations, sleep disturbances. These people are going to be really edgy, and some people might have sudden outbursts of irritability. Now, there are some genetic predispositions to PTSD. When you look at monozygotic twins, there's a really strong concordance between them. So there does seem to be a pretty strong genetic component for PTSD. So in particular, what we do find, those who basically have a family member, basically as many as 74% of PTSD sufferers have a family history of some kind of psychopathology. And that includes things like PTSD, anxiety, depression, or antisocial behavior. There is a higher concordance rate with monozygotic twins than there are with dizygotic twins, indicating that there's a strong genetic link here. We do also know that it is more likely for women to develop this disorder than for men to develop this disorder. Now, we talked a little bit about cortisol and stress hormones last time. So you might be kind of curious as to whether cortisol is very high in individuals with PTSD. And it turns out this is not actually true. Cortisol levels are actually shockingly low. One of the things that we do find is the normal feedback mechanism that turns off cortisol and ACTH is hypersensitive, ultimately leading to lower circulating cortisol as a result. So in particular, Yehuda and colleagues basically showed in high-risk populations of offspring of Holocaust survivors, those who developed PTSD themselves and actually had a parent with PTSD had the lowest levels of cortisol. So this is actually probably pretty surprising. And this may... the normal feedback mechanism might be hypersensitive. And we do know that low cortisol levels do enhance the sympathetic nervous system, ultimately resulting in higher levels of circulating norepinephrine, which might lead to those anxiety disorders. And then finally, we have obsessive compulsive disorder. This disorder is marked by recurring persistent thoughts of things like contamination, violence, sex, or religion that cause a lot of distress. These are the obsessions. And then to basically try to relieve anxiety or reduce stress in these situations, you have compulsions. These are repetitive rituals that people might engage in to relieve the anxiety that's generated by those thoughts. And they may be directly related to the obsession, or they may not be related at all. So for example, an individual may wash their hands hundreds of times until their skin is raw and bleeding because they're having the obsession of basically contracting a fatal illness. But Other compulsions are unrelated to obsessions. So compulsions may be things like counting cracks on the sidewalk, jumping through a doorway and not actually walking through, chewing each bite of food 100 times because they think that a family member might become ill if they don't do it. But basically, the individual is convinced that if they don't do these compulsions, the things that they're obsessing about may actually occur. Now, in terms of neurobiology, we know a couple of different things. In particular, it seems like the basal ganglia, particularly a region of the basal ganglia called the caudate nucleus, does seem to have a central role in OCD. And imaging actually shows activity of the caudate with several other cortical regions, and they're all kind of working together. Researchers have found high levels of metabolic activity in the basal ganglia, and so some people have actually said OCD is not an impulse control disorder. It might actually be considered a motor disorder due to the region that we're getting this high activity in. So now let's talk a little bit more specifically about the brain and anxiety disorders. So as we've talked about, the amygdala is really important when you're dealing with stressful situations. We talked about that last week when we talked about depression. The amygdala gets a lot of different information. So here we've got 3 different nuclei of the amygdala. We have the lateral nucleus, the basolateral nucleus, and the central nucleus. And these are areas of the brain that are sending information to different components of the amygdala. In particular, you are getting a lot of sensory information, things related to sights, sounds, different touches. You're getting information that is misspelled, and that should be the hippocampus. And you're also getting a lot of information from the thalamus. So it's receiving a lot of highly processed sensory and cognitive information from these different areas. Now, once it processes this information, what's important to note, it's going to be sending output to different areas, like the bed nucleus of the stria terminalis, areas like the hypothalamus, the midbrain, the pons, the medulla, and the prefrontal cortex and the hippocampus, as well as the ventral striata. So the amygdala plays a major role in both fear and anxiety. In general, we know that negative emotional stimuli, your amygdala likes emotion, but it really responds to negative emotional stimuli. So it's going to be more active looking at a fearful face than it is looking at a happy face. And so negative information tends to stick more, and it's going to be more active for that stuff. That activation, that advantage for negative emotional stimuli is going to be significantly greater in individuals that have these anxiety disorders. Additionally, we have found that in animals, if you stimulate the amygdala, you are going to see a lot of signs related to anxiety and fear. Now, on the other hand, if we damage both sides of the amygdala, we actually see deficits in fearful responses. Now, the central nucleus of the amygdala is going to be critical for responses to fear. So that includes the autonomic nervous system activation, particularly the sympathetic branch, that fight or flight system. It's going to have output that enhances our reflexes, it increases our vigilance and our arousal and our alertness, and most importantly, it activates that HPA axis that we talked about last time. So here you can actually see a lot of the different outputs and the effects that they have, not just on your physiology, but your emotional responses. So here are a variety of different outputs. We have fear and anxiety producing stimuli. Here's your amygdala. Here are a lot of different outputs. So the hypothalamus, we're going to get sympathetic activation, and we're going to see those sympathetic nervous system effects. The dorsal motor nucleus of the vagus nerve, so this is the 10th cranial nerve, we're going to get some parasympathetic activation too, like ulcers, urination, and defecation. The parabrachial nucleus, that's going to be in areas of the brainstem, increased respiration, panting and gasping for breath. Maybe if you have a cat or a dog, when they're under a lot of stress or they're scared, you might actually see them pant. Areas like the ventral tegmental area, the locus coeruleus, and the PPN, we're going to get some activation of dopamine, norepinephrine, and acetylcholine, which is all going to enhance our arousal. The reticular nucleus, we get increased reflexes and an increased startle response. The periaqueductal gray, this is going to cause defensive or predatory or defensive aggression. We're going to maybe get a freezing response. Trigeminal and facial nuclei, those are also cranial nerves. That's going to open the mouth and jaw movements and create facial fear expressions. And then the paraventricular nucleus of the hypothalamus, we're going to get that ACTH release, and that's going to really kickstart that HPA chain where we get ACTH, we get corticotropic releasing hormone, and then we're also going to eventually get that glucocorticoid release and cortisol. So I want to talk about the bed nucleus of the stria terminalis. So the amygdala, so we talked about the central nucleus for fear, but it's the bed nucleus of the stria terminalis that is more important for anxiety. And it's been suggested that the behavioral responses are actually initiated by the BNST, which actually projects to the same brain regions as the central nucleus of the amygdala. So let's take an example and compare and contrast anxiety-based fear responses. So in a fear response, the central nucleus is going to play a role in response to sudden aversive events. Remember, fear helps Riley with things she can see, and then anxiety is going to be different. The BNST is going to initiate an emotional response when stimuli aren't good predictors of potential danger. Danger might be there, but it might not. I protect Riley from the things she can't see. So this creates a sense of sustained preparedness for an unclear future danger and potentially a prolonged anticipation of unpleasantness. So you can kind of see the difference between fear and anxiety and how different parts of the brain play a role in those responses. Now, the amygdala plays a pretty important role with memory too. Remember, the amygdala is located just in front of the hippocampus. And we know that because of that close connection between the amygdala and the hippocampus, that the amygdala is going to aid in the formation of emotional memories. This could be a conditioned fear response or another conditioned emotional response. So basically, we can make an association between an environmental stimulus and an aversive stimulus, and it's established pretty quickly and it's long lasting. So an example of this is covering your ears when you see a flash of lightning in the sky. Now, odds are pretty good you've seen lightning and then you've heard a really loud thunderclap. Those are very loud noises, can be really aversive, and you learn very quickly that lightning precedes thunder, and as a result, you cover your ears or you brace yourself for the loud aversive noise that's going to occur. Additionally, the amygdala does contribute to memory consolidation through its connections with the hippocampus. Remember, they're right next to each other, so they're going to share a lot of information with each other. And then finally, I want to talk about two other areas, the prefrontal cortex and the anterior cingulate. Both of these are there to inhibit the primitive responses of the limbic system. They're largely there to basically kind of really provide a more rational response than an emotional response. And ideally, this is going to help us cope with modern situations. The problem occurs in an anxiety disorder where there's an imbalance between the emotion generating centers of the limbic system and the higher order areas like the prefrontal cortex. There's an imbalance there. The prefrontal cortex and the anterior cingulate are having trouble keeping the limbic system in check. So, what neurotransmitters are going to be involved in anxiety? And again, we're going to see some similarities to mood disorders. So, we are going to see corticotropin releasing factor or corticotropin releasing hormone, adrenocorticotropic hormone, and glucocorticoids are all going to be a part, again, of the HPA axis, just as depression involves a cycle of stress in the HPA axis. We're going to see the same thing with anxiety disorders. Additionally, we are going to see that norepinephrine is involved, GABA is involved, serotonin might be involved, as well as dopamine. So let's talk about norepinephrine's role. So the locus coeruleus is a major cluster of cells in the pons that project to several different brain areas. And it has 3 different types of neurons. So one branch of those corresponds to general wakefulness, so kind of keeping us awake and alert. Other neurons in the locus coeruleus will respond to non-noxious environmental stimuli, so just things that are going on around us to keep track of. And then there's the third type. This third type responds both to stressors and stress-induced release of corticotropin releasing hormone. Now, what evidence do we have that norepinephrine is involved in anxiety? Researchers have found that when you stimulate the locus coeruleus or you administer a drug called yohimbine, which increases norepinephrine release, and thus it's an agonist, we actually see induced alerting and fear responses in animals. And if you were to give a human yohimbine, they would start to have panic attacks. And one of the things that we think is going on is that patients with anxiety disorders have an abnormal autonomic nervous system response. And remember, norepinephrine is the primary neurotransmitter of the sympathetic nervous system. So in particular, we might experience the feelings of anxiety as kind of being overactive sympathetic nervous system. Now, what about GABA? So remember that GABA is an inhibitory amino acid neurotransmitter. Remember that we need to have some inhibition in our brain so that our brain doesn't overexcite itself to death. So GABA-induced inhibition actually helps regulate activation of the central nucleus in the amygdala. Now, in addition to this, we have glutamatergic neurons, so glutamate from the prefrontal cortex are designed to help provide top-down control of amygdala processing. If GABA is impaired, we may actually see overactive bottom-up signaling from the amygdala and underactive top-down control from the prefrontal cortex. And one of the things that we're going to find is that in addition to using SSRIs for treating anxiety disorders, we also we have benzodiazepines and barbiturates, and they're actually there to help modulate GABA. So both benzodiazepines, which I'm going to call BDZ, and barbiturates, they cause sedation and they reduce anxiety by binding at modulatory sites. So we actually find if you look at a GABA receptor, there is a binding site specifically for benzodiazepines, and they have these receptors have very high concentration in areas like the amygdala, the limbic system, and the frontal lobe. So if we can enhance GABA, we may potentially be able to reduce that anxiety. And here you can actually see a PET scan of those different binding sites. Remember that areas that are in orange and red have more active benzodiazepine binding sites than elsewhere. And we can kind of see that a lot of areas of the cortex, particularly the frontal cortex, have a lot of those binding sites present. So reductions in benzodiazepine binding have also been found in brain areas of individuals that have GAD and PTSD, meaning that you aren't getting as much binding to those benzodiazepine sites. And this reduction may result in failure of GABA to inhibit things. As a result, you may experience uncontrolled panic attacks, phobias, generalized anxiety, and the hyperarousal, the enhanced alertness and hypervigilance that we see in PTSD. Now, what about serotonin? Now, norepinephrine and GABA make a lot of sense, but it's when we get to serotonin where it gets a bit more complex. And it's so we're not going to talk as much about how it works, but what we do know is that the 1A receptor of serotonin has received the most attention, and that's why one of the first lines of treatment for anxiety is an SSRI, which blocks reuptake of serotonin, prolonging its effects. Now, here's what's really important. If you have an anxiety disorder and you are taking an SSRI, when you initially take an SSRI, you may have increased anxiety in the early phase of treatment for some people. But we do find that there are long-term adaptations beyond that quick increase in serotonin for SSRIs to be effective. So again, this is another instance where you have to take it for a while before you really get those subjective effects, even though the release of serotonin is increasing almost immediately. Now, what about dopamine? And again, just as serotonin seems to be a modulator, dopamine does as well. And that's because of the projections of dopamine from the ventral tegmental area to the medial prefrontal cortex and the limbic system. So our mesocortical dopamine pathway and our mesolimbic pathway. One of the things that we know is that stress increases the firing of mesocortical dopamine neurons, and it increases dopamine turnover in the prefrontal cortex. Now, another thing that we know beyond these neurotransmitters is that early stresses in life can affect anxiety and the brain. Early stress may permanently alter the HPA axis, causing a hyperactive hormonal response to stress. And so these are cases where epigenetic factors might play a role. There was a genetic vulnerability that basically got exposed during a traumatic event. We do know, as we talked about before, that excessive HPA activation leads to damaging effects. It leads to a buildup of cortisol and damage to the hippocampal cells. So again, prolonged stress and subsequent elevation of those glucocorticoids are going to hurt the hippocampus and potentially damage it over the long term. So now let's talk about treatments for our anxiety disorders. So anxiety is going to be relieved by drugs that are known as anxiolytics. So ideally, they should be relieving feelings of tension and worry and signs of stress with minimal side effects of things like sedation. Like, we want to reduce anxiety without knocking people out. So some of these can be called sedative hypnotic drugs. All of these are central nervous system depressants, and they do include barbiturates, benzodiazepines, and alcohol. Now, alcohol may be used by people with anxiety to self-medicate, but it will never actually be prescribed. All of these drugs are going to reduce the excitability of neurons. Now, one of the things that we do find, though, is that central nervous system depressants do share some commonalities, whether we're talking about benzodiazepines, barbiturates, or alcohol. Anxiolytics are initially, with increasing dose, they're going to produce a calm and relaxed state with potentially at higher doses, drowsiness, mental clouding, and incoordination. And at higher doses, they may actually induce sleep, which is why some of these are referred to as hypnotics. That literally translates to sleep inducing. And in fact, barbiturates are often used for purposes of general anesthesia because of those effects. But at the highest doses, all central nervous system depressants, whether benzodiazepines, barbiturates, or alcohol, will induce coma and death. So notice that these are all similar effects that you'll get, and they're all based on drug dose. So we have to be careful with these. So how did these work? And so what we're going to find with benzodiazepines and barbiturates is that the primary mechanism of action is all about enhancing GABA. In particular, GABA A receptors. They're going to regulate chlorine channels, and chlorine is a negatively charged ion. Ultimately, when the GABA receptors are activated, this increases chlorine flow into the cell, and this results in a hyperpolarization. The cell actually becomes more negative than its resting potential, and thus greater stimulation is going to be needed for that cell to fire. So we're basically inhibiting the actions of neurons by activating these receptors and allowing that chlorine flow to come in. So what do benzodiazepines do? Benzodiazepines include things like Valium. They also include drugs like Xanax, and they're basically there to enhance the effect of GABA. So you have to have GABA with a benzodiazepine for this effect to work. So what you're looking at here on your x-axis is a variety of different treatments. So GABA only, GABA plus a benzodiazepine, GABA plus a benzodiazepine and an antagonist that blocks it, GABA plus a benzodiazepine and a GABA antagonist. And what we can basically see is we're going to get an increased amount of chlorine flow only when we have GABA paired with a benzodiazepine. If we block benzodiazepine, we don't really get that much of a change as if GABA were there. But if we don't have GABA and we only have the benzodiazepine because that antagonist knocked it out, you can see that benzodiazepines can't do anything without GABA. Now, what about barbiturates? So barbiturates will include things like pentobarbital, phenobarbital, and ammobarbital. Barbiturates are going to increase the affinity of the GABA receptor for GABA, which means it's going to enhance GABA's effects. And here's what's really critical. Benzodiazepines need GABA to open. Barbiturates do not need to have GABA bind to the receptor to have that chlorine channel open. Now, this makes them lethal, while benzodiazepines are not. So you don't need GABA to bind to that GABA receptor for that chlorine channel to open. That makes them very lethal, and because of that, they've basically been replaced by benzodiazepines for treating anxiety disorders. So here are the duration of action and the uses of major barbiturates. You're probably going to see barbiturates for anesthetics or for sleep induction. So we have thiopental, has high lipid solubility. That means it's going to act fast and it has a pretty short duration. This is going to be for initial IV anesthetic that's going to knock you out before they put you under general anesthetic. We have short intermediate duration of action. That includes ammobarbital, secobarbital, and pentobarbital. This is going to be for surgical anesthetics and sleep induction. again. And then we have long acting. This is going to be for sedation and seizure control. That'll include phenobarbital and methylbarbital. And you can see that their duration, 20 to 30 minutes, 5 to 8 hours, 10 to 12 hours. Now, what are some of the different side effects of barbiturates? We will see a reduction in the amount of REM sleep. Again, because this is a depressant, mental clouding, loss of judgment, and slowed reflexes. Higher doses, because these are depressants, will lead to gross intoxication, similar to what we would see with alcohol, and coma and death will result from respiratory depression. And they're going to be, because they have similar effects to alcohol, you do not take them together. They are dangerous when they're combined with alcohol. So why are they so dangerous? We've already talked about the fact that they can basically cause chlorine to flow into a GABA receptor without GABA being present. But barbiturates are dangerous because the neurons adapt to the drug and you're going to develop a tolerance very quickly. But respiratory depression does not show a tolerance. So basically, as you want to get that effect more and more, you're developing a tolerance to the desired therapeutic effects, but the respiratory depression never changes. And so as the dose you need to achieve that therapeutic effect increases, your margin of safety, aka your therapeutic index, actually becomes smaller the more that you take it. So here you can see here with these, with our barbiturates here, here's our therapeutic effect, here's the respiratory depression. Here's what happens with tolerance. The respiratory depression doesn't change, but your therapeutic desired effect does, creating a smaller therapeutic index and a greater likelihood of overdose and death. So let's talk about the development of benzodiazepines. They were designed to be a safer version of barbiturates. First benzodiazepine to be introduced was chlorodiazepine or Librium. We also have ones like Klonopin and, as I've mentioned, Valium and Xanax. And these were designed to target anxiety without producing excessive sedation. They have low incidences of tolerance. Now, you can develop a tolerance to benzodiazepines, and you can experience withdrawal symptoms, but the withdrawal will be less severe than you would experience with barbiturates and a considerably safer therapeutic index. So here you can see a few different chemical structures of these different benzodiazepines. Diazepam, better known as Valium. Here's Librium, triazolam or Halcion, and then oxazepam or Serax. They all have a pretty similar chemical structure. Now, benzodiazepines have a variety of different uses. Whereas barbiturates can be used for anesthesia, benzodiazepines really can't. They're useful for pre-surgical anesthesia, dental work, or other procedures to basically relax the patient. When I had a root canal many years ago, I was offered the option of a Valium to help calm me, but I would have had to have somebody drive me home. And considering I had nobody to drive me at the time, I ended up taking nitrous oxide instead, laughing gas, which I later stopped taking because it was awful. Another example of a benzodiazepine is Rohypnol. And it's actually marketed outside of the United States as a sleep aid. The problem is Rohypnol in particular is what is known as roofies as a slang term, and it's become known as a date rape drug, especially when it's combined with alcohol, because again, benzodiazepines are depressants and have similar effects to alcohol. Never take a benzodiazepine with alcohol. It's just a bad deal. Now, there are some other therapeutic uses for benzodiazepines. Longer acting ones can actually help aid sleep. Some are good muscle relaxants or anticonvulsants by enhancing that GABA use, and they can prevent acute alcohol or barbiturate withdrawal symptoms. They have some similarities here, so that can help prevent some withdrawal. Now, what are some of the effects of benzodiazepines? They have a higher therapeutic index than barbiturates, so they're often going to be recommended over barbiturates. But high doses can produce disorientation, cognitive impairment, amnesia, but they don't produce the respiratory depression that you might see with barbiturates. Additionally, benzodiazepines don't induce liver enzymes. As a result, we don't get that metabolic tolerance that we would see with other types of drugs. Now, they do have a lower risk of dependence and abuse, but some does occur with chronic use. Abuse of benzodiazepines basically began in the 1960s and 70s. Valium became really popular, and because of this, a lot of benzodiazepines are actually classified as Schedule IV drugs. Now, I want to finish up by talking about second-generation anxiolytics, which you may not have necessarily heard as much about. I want to talk a little bit about buspirone, which is under the trade name Buspar. Buspirone, much like the later on, we're going to talk about schizophrenia and the third-generation antipsychotic Abilify. Buspirone is very similar in that regard, where it reduces anxiety, but it does so through a fundamentally different mechanism than benzodiazepines do. It has a novel structure, so it's not really going to look like barbiturates or benzodiazepines. And what we basically find is that buspirone does have some very clear effects in reducing anxiety, but it's not really going to do very much to reduce the physical symptoms. It's going to do a better job with the cognitive aspects of anxiety, like the worry, the poor concentration. And some have recommended that it can be it works best when it's paired potentially with other drugs or with therapy. But buspirone has some advantages over benzodiazepines even. It helps treat depression that might accompany anxiety. Additionally, this anxiety reduction, it's not accompanied by sedation, confusion, or mental clouding, and it doesn't enhance the depressant effects of alcohol, so it's going to be safer than benzodiazepines. It doesn't really have a lot of severe side effects, and it doesn't nobody's died from this. Additionally, it doesn't really have a lot of potential for recreational use or dependence. And some people have mentioned that they really don't like it. And additionally, there's no withdrawal syndrome. Now, generally, you don't want to take prescription medications and just suddenly stop taking them. So you should never ever do this. But if you wanted to suddenly stop taking buspirone, you could probably do it without too much of a problem. Now, one of the downsides, so I've already kind of talked about the benefits. It treats the depression that accompanies anxiety. It's not accompanied by that sedation, confusion, or mental clouding, and it doesn't enhance the effects of alcohol or other depressants because it works in a totally different way. But the downsides are that the onset is very long. Because of that, usually it takes at least 6 weeks to really start getting a therapeutic effect. And additionally, sometimes the side effects, people don't always feel good when they take it. They feel a sense of malaise. And additionally, its effectiveness in relieving anxiety is going to be less than you would see for benzodiazepines. So this is going to make it really unhelpful for somebody who has something like situational anxiety. They get anxiety when they fly, or they get panic attacks. Like buspirone's not really going to work very well for this. Buspirone works great for people with generalized anxiety disorder, though, because they feel anxiety all the time. So buspirone can be great for GAD. It's not really going to work well otherwise. And additionally, you can't use it for alcohol or barbiturate withdrawal the way you can with benzodiazepines because, again, this works through a very different mechanism. Additionally, it's not going to be able to treat because it's not working in the same mechanism. It doesn't really do a very good job of treating insomnia. It doesn't have any muscle relaxing effects, and it can't control seizures. So for those of you who are kind of curious, buspirone works the way it does because it works on the serotonin 1A receptor as a partial agonist. So it's working more on serotonin than it is on GABA. Now, that actually brings us into another potential idea because buspirone is a partial agonist. SSRIs can be used to treat anxiety. And we are going to find that with a lot of people who take this, the symptoms are lessened, but they're not necessarily eliminated. And again, much like the very long time for buspirone, antidepressants take about 4 to 6 weeks to actually produce subjective change. And benzodiazepines don't work that way. They act immediately, and please ignore my poor spelling. So here you can see some of the different treatments that you can use for anxiety disorder. So we have our benzodiazepines, Valium and Xanax, GAD, panic disorder, OCD, social phobia, alcohol withdrawal, acute situational anxiety. We have our tricyclics, our MAO inhibitors, our SSRIs, and then buspirone. So folks, this is all I had today. Next time, we are going to talk about schizophrenia and treatment of schizophrenia through antipsychotics. I'll see you then.